Good afternoon. Thank you so much for joining us in today's panel. I'm Maria Guadalupe Ortiz-Briones, your moderator for this session, and we're going to be talking about health disparities among hard-hit populations. These experts will explain how important representation of people of color in drug trials is to improve health outcomes across racial and ethnic groups, as well as social determinants of health that contribute to health disparities in people of color, and how important it is for news outlets to not ignore coverage of those hard-hit populations, especially during a pandemic, just to mention a few topics that we're going to be covering. I am pleased to introduce our three experts. With us today is Dr. Bumpus, who is the chair of the Department of Pharmacology and Molecular Science at the Johns Hopkins University School of Medicine. Her research has focused on understanding the molecular basis of inter-individual differences in drug outcomes. We also had Dr. Alvarez, assistant professor at Johns Hopkins School of Nursing. She's also a family nurse practitioner serving uninsured and underinsured populations. Her research focused on the development and implementation of health promotion interventions for underserved ethnic groups with history of adverse childhood experiences and intimate partner violence. And last but not least, we have reporter Stephanie Inez, who covers health with a focus on patient safety, hospital quality, consumer experiences, and health policy for the Arizona Republic. Just a reminder, we're going to hold questions for all panelists until everyone has presented, but feel free to submit your questions anytime during the session. We're also going to have breakout rooms following the conversation, so please hang around for that. Now, let's go to Dr. Bumpus.
Thank you. So thanks for that introduction, and thank you for the invitation to participate in this exciting panel. So, as was mentioned, I'm really a basic scientist, a translational scientist. I focus on understanding mechanisms of drug outcomes and why some people respond differently. So in the context of thinking about COVID-19 and hard-hit populations, I think it's important to start to think about this real scientific basis for differences in drug outcomes, because as we develop drugs for COVID-19, it's imperative to make sure that they're going to work for all, particularly the people that are disproportionately impacted. I've heard some discussion, in the media and even among scientists that diversification of clinical trials is really a political issue, that it's not a scientific issue. And actually, I believe that we do have a strong scientific basis for diversification of clinical trials. So I wanted to begin and talk about that. So my remarks will just be a few minutes focused on that topic. So one issue is that representation of African Americans and others, Latinx people, indigenous people, remains low in COVID-19 vaccine trials. In the context of the drug trials, including drugs that are being touted as changing clinical practice and will be very useful for people with severe conditions related to COVID-19, we don't even know the demographics in most of these clinical studies. So we really have no idea who they've been tested in. We don't know, that they'll work for all. That information just hasn't been reported. So I think it's something important to start to bring light to, but also to understand the importance of doing so. So, the fact of the matter is that there are dozens of drugs that are approved for use that have been shown to have different outcomes in exposure or even just efficacy, toxicity across ethnic groups. So for instance, in drugs that were approved between 2008 and 2013 by the FDA, it was shown that about 20% of those drugs exhibited differences with when you looked at ethnicity. So that's 20% of drugs approved just in that 5-year period. So if we're talking about, everything on the market, there's a substantial number of drugs, as mentioned, dozens and dozens, that have been shown to have this sensitivity. So it means that when we're developing new drugs, it really is important to keep this in mind, to do this testing, and to be transparent about who you've included in your study so that we can start to determine whether we can even know from your data if there are differences with ethnicity. So even though we know that there are drugs that have these differential outcomes with that are sensitive to ethnicity, still, representation of, so-called minority groups, Black people, Latinx people, indigenous people, remain low in clinical trials. So, for instance, this has been best studied in the context of cancer. So I'll just give you some data there. But as I mentioned, for COVID-19, most studies we just don't know, who's been included. So if you look at, for a 10-year period, for cancer trials from 2008 to 2018 that led to drug approval, so there were 230 clinical trials, and it turned out that only 38% of those trials reported the number of Black participants in the study. Only 10% reported on Latinx people. So that means that for a number of these drugs, the clinical studies that led to their approval, we actually have no idea if they were tested in people from underrepresented populations who actually are indeed often disproportionately impacted by the cancers that drugs are used to treat. So it's found that overall, when you looked at, that was the number of studies that included Black and Latinx people. When you looked at the overall number of participants that were Black or Latinx in these studies, it was found that only 3.1% were Black and 6.1% were identified themselves as being Latinx. So that means that, that's a very small group. That's much smaller than the population of folks, as far as their overall representation in the U.S. population. When you account for the incidence of cancer, so when you thought about, okay, based on the incidence of cancer, how much would we expect these people to be enrolled? It was found that, for instance, Black people were only 22% of what we'd expect based on the rate at which they're getting these cancers, where for white people, for instance, it was 98%. So their enrollment was really spot on with the incidence of cancer. But for Black people, 22%. For Latinx people, 44%. So this underrepresentation is a huge issue. But with COVID-19, we have a chance to really do this right and start diversifying these clinical studies. So why does this matter? So I told you there are differences across race, ethnicity, and really what underlies this seem to be some genetic differences. So, I want to say, I think what we all know is that humans are more similar than we are different, where the genetic differences between people are very, very small. I certainly don't want to give any credibility to people that have tried to use genetic differences as a reason to suggest that, health disparities that exist are, natural and related to genetics or, other kind of really ways that people use genetics to try to support systemic racism. So we're mostly similar, but there are some real differences that exist in the way that we process and handle drugs, and that can be very important in our drug response. So I really want to highlight that. And just, one finding, we even think about genetics, what we know about DNA in people. It turns out what we call the reference genome, so the genomes that we use to really say, what are the genes expressed in people? If you have, a variant, how is it determined that your genetics are different? What is the reference we're using for genomes? That really comes from a few, mostly men, of European descent. So if you look at people of African descent, it's been found that actually there are a number of genes that are different. There's up to 10% more DNA in that genome than has been found in other genomes. And so again, we are mostly similar, but there are some differences particularly relevant to pharmacology that are important to think about. These genetic studies, because they mostly focus on people of European descent, we often don't even fully understand the impact of these genes that are different and that are specific to, for instance, people of African descent. But I want to at least give you some examples of where we know what the differences are. And I'll first kind of introduce you to why we think about these differences scientifically. So many of the differences that I talked about, the genetic differences between people that really can lead to different outcomes, are related to a process called drug metabolism. So this is basically the way that our bodies get rid of drugs. But it's a very involved biochemical process. And there are a lot of different proteins involved, and each of those proteins can be different in different people. So it means that you can have differences in drug response that are really related to how you process drugs differently than others. It turns out that many of those differences seem to really be ethnically linked. So, thinking about our kind of ancestral geographic origins, many of the differences we see between people really seem to be closely linked with that, close with kind of that geographic ancestral origin area. And it may be because of things that we are exposed to in those environments. Our body evolved ways to deal with those different chemicals and compounds, and now those same processes can act on drugs. So essentially what happens in this process of drug metabolism is that, drugs so that our body can absorb them, so that they can get into your cells, are fat soluble. So drugs are made to be able to get into your cells. Cells basically have a layer of fat around them. But then your body needs to get rid of them. So we've designed the drug to get in, but your body says, hey, wait a minute, this is something foreign, I need to get rid of it. So it has these proteins that we call drug metabolizing enzymes that act on the drug to make it more water soluble. So here, basically, I'm showing you a drug comes in, there's blood flow that, pushes it really through the liver. And what we look at, the kind of blowout, is one cell, liver cell. So if the drug has blood flow across the liver cell, there's transporters to bring it in. So now it's in your cell. And so there's these proteins. So one are called the cytochromes P450. So you see the P450 there. And what those really do, they change the drug, they insert oxygen into it. They change that drug into something that is water soluble to get out of your cell. The reason I want to highlight it here is because about 75% of drugs we take, this is the way that they're cleared from our bodies. These proteins, P450s, change them into something we call a metabolite or a product, and those then are able to exit our body. There are many, 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 many hundreds of genetic variants that have been identified in P450s, and they really underlie differences between people in outcomes. There's a strong link oftentimes, as I mentioned, as far as ethnicity and our ability to process drugs through these P450s. So I wanted to give you a few examples that I think really lay the foundation for why we need to think about this in drugs for COVID-19. So, as I mentioned, we have the genetic variants. Drug metabolism, we have hundreds of them, many, many, many. We don't know what they all do, but we know that they're there, and they tend to be oftentimes more prevalent in certain ethnic groups. Much of what we've studied in pharmacology as far as how drugs work has been done in people of European descent. So we often don't really know the function of variants that exist in other populations. But there are some instances where the effects have been so large that we actually do see these ethnic differences, and we've been able to trace it to specific genetic variants. This same type of work could be done, as I mentioned, in thinking about COVID-19 drugs. So I wanted to give you just 3 examples of drugs that are commonly used that have much different outcomes, marked differences in outcomes in people of African descent versus people of European descent. So, for instance, I told you about P450s, how they help us clear all these drugs. So there's a P450 that we call 3A5. And that P450, it turns out, is not present in about 90% of people of European descent. But people of African descent tend to have this P450, and it's very active. Other populations have been shown to fall kind of somewhere in between. So if we have a drug that relies on P450-3A5 to get out of your body, and we've measured that dosing based on European people that don't have it, it means that the dosing is based on people that can't get rid of it easily. So now you give that drug to someone like me of African descent that has it, and I'm going to get rid of it quickly. So you might be dosing me improperly. So how this plays out, for instance, we look at tacrolimus. So we see that there are differential outcomes with ethnicity. So for instance, there is a higher risk of rejection. So this is used to prevent organ transplant rejection. There's a higher instance of rejection following kidney transplant African Americans compared to European Americans. And we know it's because of this genetic difference in drug metabolism. Similarly, it's been shown that you can use much lower doses in people of European descent than you need in people of African descent. And so not only do you have this rejection that can occur, which obviously, is a really bad outcome, but also that there are dose adjustments that are required when you look at these different ethnicities. And that's really because of the prevalence of this disease. Another one is warfarin, which is a blood thinner anticoagulant. African Americans are at 58% higher risk of major bleeding that, means hospitalization from this drug than people of European descent. And that's, again, because of variation, particularly in drug metabolism. A lot of the algorithms for dosing this drug have been based on people of European or even in some cases Asian ancestry. It's been shown that those just don't work for people of African descent. Because of these genetic variations, we even need a different dosing algorithm. We wouldn't know that if people of African descent hadn't been taking this drug. So this is something that we can test through diversifying our clinical trials to try to mitigate some of these extreme side effects that can happen, once people are taking a drug. And just the final example that I wanted to give you is clopidogrel. So it's an antiplatelet drug that's used to reduce the risk of heart disease and stroke. And similarly, it has this difference with ethnicity that we know is really linked to genetic differences in drug metabolism. So it's been shown, for instance, that there's a specific genetic variant that African American people have that leads to a substantially increased risk of 1 year mortality when they're taking this drug compared to people of European descent. In addition, they have a severe increased risk of bleeding. African Americans have an increased risk of bleeding. So these are just instances where we know the gene. We know there's science there. We know that these genetics are linked to ethnic background. They're more prevalent in certain ethnicities. So this is something we need to think about for every drug. We will not have an idea whether the dosing is correct, what the outcomes will be, whether they're the good outcomes, will the drug work, or the toxic outcomes, if we don't test this drug in a range of people. And further, I would go a step further and say we need to diversify the scientists and the medical doctors that are engaged so that these things are top of mind. These genetic variations that we know exist are top of mind, and some of them we can actually predict without even having to fully do the clinical studies. So I believe there's a strong scientific rationale, and I think that the lack of inclusivity in clinical trials only exacerbates the disparities that we see in certain diseases, including COVID-19. And so those are my remarks, and thanks for listening.
Thank you, Dr. Bumpus, for the presentation. It was very informative. And now let's hear for Dr. Alvarez.
Well, good afternoon, and thank you for having me here today. I will be speaking about the impact of COVID-19 on Latino health disparities and how the burden that many Latinos are currently experiencing is largely a function of social determinants of health, which means that the persisting disparities are preventable. So there has been growing recognition that the conditions in which people are born, grow, work, live, and age, also known as the social determinants of health, most explain health behavior and health outcomes compared to access to clinical services. Social determinants of health include factors such as economic stability, neighborhood and physical environment, community and social context, and healthcare services. The County Health Rankings model offers another visual of how influential socioeconomic factors and the built environment contribute to health outcomes relative to access to care. Health behavior is also a significant determinant of health outcomes, and health behavior is that with a population of almost 60 million and comprising 18% of the U.S. population, Latinos are one of the fastest and largest growing ethnic groups. This is also a very diverse group representing the spectrum of races and over 15 different groups when categorized by country of origin. And we are increasingly seeing representation of groups for whom Spanish is not the primary language. And here are just a few of the preferred languages of some of the Latina women we work with in Baltimore. So Mixteco, Zipacapense, Chinantenango, and Garifuna. Given the growth of Latinos, it is worth mentioning their significant contribution to the U.S. economy. According to the New American Economy Research Fund, in 2015, Latino earnings contributed $215 billion to tax revenue and to entitlement programs, particularly Social Security and Medicare. Despite these contributions, Latinos remain systematically disadvantaged and experience an array of health disparities. To highlight, compared to non-Latino whites, Latinos are less likely to be insured, more likely to be obese, more likely to have diabetes and die from it. And although Latinos are less likely than non-Latino whites to have hypertension, they are more likely to be uncontrolled. And I highlight these health problems because they contribute to the leading causes of death among Latinos. Latinos also experience disparate care for mental illness. Although Latinos do not have higher rates of depression compared to non-Latino whites, they are less likely to receive treatment for depression. When looking more specifically at immigrant Latinos, the longer they reside in the United States, the greater their risk for poor mental health. So given the limitations of access to care, immigrant Latinos with depression or other mental illness are at increased risk for remaining in poor mental health. So social determinants of health are major contributors to all of the aforementioned disparities. Latinos are highly represented in industries that do not provide a living wage or benefits, resulting in many having to work multiple jobs to make their basic needs, to have their basic needs met. Latino workers are also more likely to live in poverty or high deprivation areas. So you can follow the associations here to understand how not earning a living wage limits options to living in deprived areas, which often negatively influences health behaviors. Also, the low wage and unstable jobs in which Latinos often work typically do not offer health insurance, which is also a barrier to accessing health care. According to data from the CDC, Latinos are disproportionately affected by COVID-19. Although Latinos comprise 18% of the population, they make up almost 27% of all cases of COVID-19. Latinos also have the highest age-adjusted rates of COVID-related hospitalizations. And we see a similar trend when we look at COVID-related deaths. Latinos also have disproportionately high percentage of COVID-related deaths. When we look at the bars on this graph for each race or racial ethnic group, the lavender bar shows the proportion of the ethnic group in the United States. Non-Hispanic whites comprise approximately 59% of the population and almost 25% of COVID-related deaths. When we look at the bars for Latinos, we see that they comprise almost 18% of the population, yet contribute to almost 40% of COVID-related deaths. So just like how social determinants of health contributed to the previously mentioned disparities that predated the pandemic, the same inequities in the social determinants of health are suggested to explain the disproportionate impact of COVID-19 on Latinos and other ethnic groups. Latinos are more likely to reside in communities with higher density of housing and reside in multi-generational households, which contribute to risk of exposure. Latinos are also more likely to reside in spaces with low air quality, which has been identified as a risk factor for infection and mortality. Latinos are also more likely to work in the service industry with less opportunity for telework. And as I noted earlier, this is a population that is less likely to have access to health insurance, which also impacts access to testing. During this pandemic, employment status has emerged as a double-edged sword for Latinos. Not being employed decreases access to resources that may offer protection from infection, not to mention the psychological or psychosocial stress that emerges with being unemployed and having a family to support. At the same time, being employed, particularly in the service industry that does not allow for telework, increases one's risk for exposure. So to highlight this work by Bui and others, presented data from COVID outbreaks in Utah, the majority of which occurred in workplace settings, such as in the manufacturing and construction industries. And although Latinos did not comprise the majority of workers in these settings, they were the most likely to be infected. So now I'll shift to some of the work that I'm doing with Latinas within the community and share what I'm hearing and learning from them. My research focuses on improving psychosocial well-being among survivors of adverse childhood experiences. And my current project called Cuidándome, which means taking care of myself, includes developing an intervention for Latina immigrant women who are survivors of adverse childhood experiences and also have depression or anxiety. So adverse childhood experiences refer to an array of experiences that occur under the age of 18 and they refer to physical, emotional, and sexual abuse, physical and emotional neglect, and household dysfunction, including living with an adult with mental illness, substance misuse, or having divorced parents. Researchers have also established that ACEs are a risk factor for poorer health behaviors and poorer physical and mental health. There's also a dose-response relationship where experiencing more than one form of abuse is associated with greater risk for poorer health behaviors and health, particularly depression and anxiety. So the first part of our project involves conducting a survey to establish whether adverse childhood experiences were also associated with social problem solving and mental health. So we recruited a sample of women from East Baltimore last year, and here are some of the demographic characteristics of our sample. On average, our participants were 31 years old. The majority had less than a high school education and were unemployed. The majority of our participants also came from the Northern Triangle, Honduras, El Salvador, and Guatemala, nations which have some of the highest rates of violence globally. Here are the frequencies of ACEs reported, so primarily physical abuse, community violence, and family dysfunction being the most common. For mental health, overall the majority, approximately 55% of the women reported depression symptoms. For anxiety, approximately 46% reported anxiety symptoms, and approximately 64% had both depression and anxiety. I mentioned earlier that we were looking to see whether there was an association between social problem solving and adverse childhood experiences. Social problem solving is a cognitive behavioral process used to cope with life stressors. And in our sample, we found that ACEs was associated with lower social problem solving, and that lower social problem solving was associated with greater depression and anxiety. So our intervention is based on problem solving because there's a strong evidence base for problem solving in mental health. Problem-solving therapy is a cognitive therapy for improving coping effectively with daily challenges and stress. It is also associated with faster reduction of depression symptoms and with more adaptive coping behaviors. And there's also a focus on skills training and strategies for recognition and management of one's stressors. So based on the evidence for problem-solving therapy for improving mental health, and our findings that ACEs are negatively associated with problem solving, we had good evidence to proceed with our plan to adapt and pilot this problem solving intervention, which we've named Cuidándome. So we're developing this intervention working hand in hand with Latina immigrant survivors of ACEs. And in working with our population, we are learning about how COVID is impacting their lives. Again, we're working with women with a history of trauma and who already have depression and anxiety symptoms. And because they already have depression or anxiety, and our project is one in development and also experimental, we provide women with community resources and services to get professional help. However, because of the pandemic, accessing these resources, particularly resources that are language concordant and affordable, has been even more challenging. Women have told us that they often call for help and they don't get responses. Some women have shared that they've noticed that their depression and anxiety symptoms are worsening because COVID has exacerbated many of the challenges that they were already experiencing pre-COVID, particularly with finances. So pre-COVID, 60% of our participants reported not having enough money to cover basic needs. 40% already had issues with reliable transportation. So these are issues that are just worsening as the pandemic continues. Home responsibilities have intensified, given that they now also have to support their children with online learning. This is yet another stressor. Given the language and technology barrier, women have shared how bad they often feel not being able to be more helpful with their children when challenges arise, particularly around connectivity and communication with teachers. And then there are the childcare concerns when they do have to go to work. Who is reliable? Who can safely watch their child and in a way that's also affordable? And we're also hearing a lot more about isolation due to concerns of exposure, something that we don't want in people who have mental illness and chronic burdens. We want people to be engaged in a positive social network. So it is very disconcerting as a provider and researcher to learn about the increased stress and worsening mental health that women are experiencing through the pandemic, again, because professional services remain limited. And when we consider the fact that most of the women we work with are also mothers of young children, one can't help but wonder how the mother's increased stress impacts the well-being of her children. In fact, there is research to show that maternal stress and depression negatively impacts child well-being. Data from the Robert Wood Johnson Foundation shows that Latino households are more likely to experience financial difficulty compared to other races. So when we take into consideration that living with an adult with mental illness is an adverse childhood experience, financial stress increases tension in the home, and that the protective factor of social support has been disrupted due to COVID, there is the potential for serious long-term effects on Latino families and children that may further exacerbate disparities that predated COVID-19. So to summarize, Latinos continue to experience an array of health disparities that have been worsened by the pandemic. Mental health disparities are likely worsening. The need for community-based, accessible resources to support mental health challenges remain, and Latino families, particularly those with children in the home, are in critical need of safe options to meet their basic needs. So those are my remarks, and thank you.
Thank you, Dr. Alvarez, for the information. Now let's hear from reporter Stephanie Innes.
Thanks very much, Maria, and thanks for having this session. And I apologize that I'm the reason this started late. We're having another surge of COVID in Arizona, and a lot of the time is blending into each other because everything is happening at once. And interestingly enough, one of our surges, which people are sort of debating whether this is a second or third surge, but it's on the Navajo reservation, which is actually where our outbreak began in Arizona, our major outbreak. So we have 22 federally recognized tribes in Arizona. And back in March, there was a religious rally in a community on the Navajo Nation called Chilchinbeto. And this rally brought people from all over the Navajo Nation, which actually covers 3 states. It includes parts of Arizona, New Mexico, and Utah. And about 2 weeks later, there was an increase in cases in the Navajo Nation. And because people came from all over, the cases were mostly centered around Chilchinbeto, but they were turning up in New Mexico and Utah as well. And, you know, a lot of people were sort of questioning why this was happening because, as we know, the Navajo reservation is so spread out. So it wasn't densely populated like New York City. And so why were their rates actually for a time rivaling that of New York City? And the answers were that, you know, people on the reservation are more likely to live in households with multi-generations. There also is there are communities there that don't have their own water supply. So there's sometimes an issue with, you know, if you're at a family gathering, but, you know, there's not always water available. So there was that issue. And there was also the issue of just, you know, at that point, there wasn't a lot known about COVID. I mean, people weren't even wearing masks a lot of the time back then. So I actually traveled up there right after they had their outbreak and went to the hospital in Tuba City and was fortunate enough to interview a Navajo doctor up there who had actually grown up in Tuba City and went back east to get her medical degree and then came back. And she said that, Navajo people are very family-oriented, and they have a lot of big family gatherings, and that is also different from non-Navajo culture. I know a lot of Hispanic and Mexican families do those big gatherings as well, but the non-minority population isn't as likely to do that. And on the Navajo Nation, it's a huge part of their lives. There was also some misinformation circulating up there at the time that sweat lodges would get rid of the virus. And this doctor that I interviewed was a wonderful person to dispel those myths. She started going on the radio once a week and giving out public messaging, which was people were far more likely to respond to that than they would be to respond to a white public health official, right? They want to hear from another Navajo person who can say, look, this is why it's spreading. This is why it's dangerous. And, a sweat lodge might be good to do and do it with your immediate household members. Don't do it with people that you don't know who aren't, say, in your quarantine bubble. I think that a lot of that helped. Unfortunately, the cases there did get really bad. And right now, about 4.6% of our population in Arizona is Native American, and they account for what we know are 11% of the COVID deaths, possibly more because there are approximately 10% of deaths that they don't have a racial or ethnic breakdown for. And there's an organization called APM Research Lab that I highly recommend if anyone is writing about health disparities. They've done a lot of research on COVID and outcomes in minority populations, and they found that 1 in 875 Black Americans has died of COVID, which is the worst rate in the country for any ethnic minority. And for Indigenous Americans, it's 1 in 925. For Latino Americans, it's 1 in 2,075 has died. And for white Americans, it's 1 in 6,025. So you can see the disparities are there. And for any of us who have been health reporters for any length of time, we know that COVID has really just amplified, as the previous two speakers spoke about, it's only amplified health disparities that have been there for so long. And any of us who have written about zip code, outcomes, life expectancy according to zip codes, or obesity or diabetes, we know that there are major health disparities in terms of outcome. And I actually had a reader write to me just this week, so it was very appropriate, and say, one of my stories quoted somebody talking about structural racism. And he said, you're just so, he meant to be mean about it to me. We've got a lot of people in Arizona who still feel that the virus is a hoax. So there's a lot of challenges, but this particular man said to me, you don't know what you're talking about. A virus doesn't understand structural racism. And, I thought to myself, that was intended to be like a criticism of my reporting. And in a way, he was right. It's our job to help people understand this and not just throw around a phrase like structural racism, but actually show how it's happening. And a good example of somebody showing that, it wasn't my story, but a reporter at my paper went to the community of Maryvale during the summer when testing was just amping up. And it's one of our lower income areas. And she found that people were waiting in line for 13 hours just to get a test. Whereas up in Scottsdale, our higher income area, people were waiting maybe 10 or 15 minutes. And after she wrote that article, it got a whole lot of attention. People understood, it made sense. She quoted people saying this community has been historically ignored. and they're not paying attention. And here, this is a population that is actually getting COVID-19 at a higher rate. The state did pay attention, and they put in more testing in that area with more staffing, and the lineups abated. So that's an example of how journalism can help with some of the problems that we're seeing. I think that there's a lot of work to be done, and when I've proposed stories to my editor saying, I want to write about health disparities and COVID, he's just like, that sounds really boring. It's better for me to say, I'm going to write about a family, multi-generational Latino family in Tucson that has had 3 people die, 5 people who got infected, and most of them are essential healthcare workers, where they're caregivers, they work in grocery stores. They're out in the community, keeping our community running, and then they're getting COVID. That's a much more relatable story than me saying, this is a story about health disparities. So it's sort of taking it to that next level and figuring out how to tell the story that's going to make a difference for our readers. Throughout the summer, I was able to spend time in a COVID ward in our county hospital, and that's where they have mostly patients from that zip code, 85008, one of the highest COVID rates in the Phoenix area. Very high percentage of minority populations, a lot of Spanish speakers, a lot of indigenous people, but mostly Latino people. And so I was able to get in there and try to tell that story. I'm not sure how good a job I did, but it was very telling to see the patients in there who, some of them had been afraid of just what we talked about in the previous speaker was, there was a fear of getting health care in the first place. Sometimes they're not insured. We've got this public charge rule right now that's causing a lot of fear in immigrant families, where people are afraid that they're going to lose their immigration status if they seek health care. So this was a population that when I talked to the people in the emergency room and to the translators in the emergency room, a lot of people were not seeking health care until they were really, really sick. Whether that's a mentality born from pre-ACA, from being uninsured, from just being afraid. It's certainly something that has gone through generations in a lot of families where, they are having trouble breathing, but they're going to try to take care of it at home and until they end up in the emergency room. And even then, there was a doctor there who said, they were doing COVID tests, and some people were okay enough to go home, and he'd say, you've got to tell your work about this. And there were a lot of people who work in landscaping and construction, and they didn't want to tell their work because they didn't get paid time off, and they were afraid of not providing for their families. And in this economy, they're afraid of losing their jobs. And there was a 36-year-old woman in the COVID ICU when I was there, and every day I asked to go see her because she was just somebody that, when I looked at her, she was not conscious. I mean, she was heavily sedated. She had this big high ponytail and in a braid, and she looked so young to me. She looked so much younger than 36, and 36 is already young. And I learned she had 3 little kids at home. Her husband works in construction, and he was afraid of losing his job, and they had to get family members in to help look after the kids. And I don't even know, the hospital said, I don't know if her husband was infected or not, but he was certainly not going to leave his job. And she had pre-existing health conditions. She had diabetes before she got sick, and she ended up passing away. And, and I don't know what has happened to that family, but I do know that, she didn't seek care until she was really, really sick. So just similar to that pattern. And a few sources for journalists out there looking for some of these stories. There are community health workers that are, there's a community health worker association in Arizona, and I'm sure there are in other states too. And they've been really helpful to me to get families that maybe wouldn't always necessarily want to talk. And they are kind of like liaisons between doctors and hospitals, and encourage people to sign them up for health insurance and say, hey, the public charge rule, that doesn't apply to you, and it's okay to get health insurance, and no one's going to take away your immigration status if you get Medicaid, if you sign up for Obamacare, that kind of thing. So they're really helpful. And yeah, and then the other thing is just talking to people who are, who are going through this. And one woman in Arizona, is Kristen Urquiza, has made a big sort of splash about this. She was at the Democratic National Convention. Her dad got COVID. They live in South Phoenix, which is an underserved community, and he died. And she's brought a lot of attention to this issue and to health disparities, which she feels were a part of her father's death. And then other than that, the APM research, and there's a serology study came out of Stanford in September, which confirmed that it was looking for antibodies in people who had COVID, and it confirmed that people in higher density and in ethnic minority populations were more likely to have antibodies to COVID, meaning they had a higher infection rate. So it's not just anecdotal. And I know that, there are genetic differences that we talked about with the vaccine, but I also think it's really important for us as journalists to try to show as best as possible these disparities that have been there for so long, that we health reporters have been trying to write about. Not everybody has always paid attention, but now with COVID-19, I think it's a really great opportunity to highlight these inequities that have been there for so long in terms of access to healthcare and in terms of coverage. Why aren't people getting Medicaid? Why are people uninsured? Why are they not going to the doctor? I mean, that's another thing. It's because they're not seeing doctors and nurses who look like them and who understand their families. So I'll leave it at that, and we can go to questions. Thank you.
Thank you, Stephanie. That was very informative. So now let's go to some questions that have been submitted. So I believe this could be answered by Dr. Bumpers and Dr. Alvarez. What are your concerns about any hesitancy of accepting COVID-19 vaccinations or those without good access to these vaccinations among people who are already experiencing health disparities?
Yes, I think I can maybe just take the first part of that. I think is, just for vaccines to really be effective, even though the data we show so far, they're effective, on their own, but you need uptake in the population. So we need people to feel comfortable and feel trust, both in the science, but also just in, healthcare in general, that these are products that they can use and will protect them. But I think that numbers are going to be important. If, we have a safe vaccine for it to be effective, we're going to need uptake, across the world. People are going to need to use it and feel comfortable.
Right. I agree with Dr. Bumpus, and I think one concern is that our populations remain unnecessarily affected by COVID if they are not getting the vaccine as recommended. So I think this is definitely a role for, as Ms. Ina shared, a role for our community health workers, a role for our providers, for other trusted members in our community to share the science and encourage our underserved and hard-hit populations to get the vaccine.
Another question that we have is about ACEs and the other toxic stress elements. In the context of this pandemic, will this stressor mean that the pandemic effects will linger longer than many other populations? And the second part is, and if so, are efforts existing to get ready for the post-pandemic needs?
Yes, thank you for that question. I think that remains to be seen. I don't want to ignore the fact that a lot of survivors of trauma are also very resilient. And so it is possible that the compounding stressors that are brought on by COVID does result in poor mental health in a population that already has a high likelihood of having not just poor mental health, but having poorly treated mental health. So I think that remains to be seen. And there was another part to the question that I forgot.
Well, if so, are efforts existing to get ready for the post-pandemic needs?
Yes, so one thing that has been happening pre-COVID has been a greater attention to trauma-informed care. And so to the extent that that continues, perhaps this may help us draw more attention to survivors of adverse childhood experiences or other toxic stress and be more attentive to their needs. So be more mindful to screen for mental illness and work more closely with them to address their condition.
Thank you. We have another question, and here it is what are the most effective ways to reach out to communities most impacted by COVID, and specifically to find human voices firsthand experience? So I guess that will be for Stephanie.
Yeah, so that is a challenge, getting firsthand experience. I find the hospitals have been somewhat helpful, but they usually, trot out patients once they're all well, and that's not always what we're looking for. We want the whole experience and not just, the miraculous patient who got through ECMO. I do know, forming relationships with some of the people at the hospitals and also with the community health workers. It might not happen right away, but then they'll think of you and will let you know. But you just have to keep being persistent about it. I do know the county hospital where I basically followed 2 ICU nurses for a couple of months. And I got to know the staff a bit. And when you do that, I kept saying to them, I want to talk to a patient. And all the patients were sedated. I mean, I couldn't talk to a patient on a ventilator. But they were able to get me a patient who actually had just been taken off a ventilator. I was able to interview him by Skype. And he also was able to send me pictures of himself when he was on a ventilator. And I kind of was able to follow his progress. And, he's still having problems now. But that was a result of a lot of, I can't tell you how many times I asked them for that patient. I mean, it was over 12 that I finally could get that person. I do find as the pandemic has gone on, it's been easier to find people, through social media, just through contacts. I know the family in Tucson that I'm profiling, I found through an acquaintance. It was actually somebody who was cleaning somebody else's house, and her whole family has been affected. And so I was able to get the connection that way, just through people that you know. But I do think the community health workers are an excellent source. And, even if you can't talk to the patients directly, they have a lot of they're just really good interviews. You know, they have so much humanity. They've usually grown up in that neighborhood. There's a woman here named Berta Carbajal, and she just knows everybody. She knows all the issues, and she can connect you to whoever. So it's finding that connector person, you know, that I think can really lead you to the families, because families aren't typically families don't ever want to talk to me unless there's somebody that they trust who says it's okay to talk to me. I find it very rare that somebody would want to talk just if me cold calling or just, you know, finding without a connection. I don't think that would work, because it's such a sensitive thing. And, you know, to talk about your health, especially if you're writing about, you know, the reasons why they might be a disproportionately affected population. So, you know, it's certainly sensitive, but I think that it's also really possible to get those good interviews.
I would also add using the radio. Local Spanish radio, I think, would be a great platform to get the word out about, well, the facts about COVID-19, and also encouraging people to get the vaccine provided as recommended and demonstrated to be effective, which so far it has been demonstrated to be effective.
Thank you. We have another question, and they're asking, are medical, pharmacy, and nursing schools teaching their students about pharmacogenic difference when treating patients of color? So,
that's a good question. Yeah. So our med school at Hopkins definitely does, and I give lectures on that personally, actually. Our med students get some, in our science, you know, PhD students too, because I think it's important, even at the drug discovery, drug development stage, to think about this as we progress. I know that there are other schools that teach us as well, but I certainly think there's always more that we can do. There's certainly room for things like national courses. You know, I think that there certainly should be a national resource for folks, and something that can inform people that aren't in healthcare. I think that it's important even just to be empowered in knowing about yourself and what the possibilities are, and being empowered when you're having those conversations with your doctor, or even with your pharmacist. So some is being taught in schools, but I think there's a lot of space to really expand, both across healthcare, education, but also to the general population.
Dr. Avalos would like to add something to it?
No, I would agree with what Dr. Burgess has shared, that I think it is something that is being addressed with our healthcare students, but of course there's always room to expand. We're finally, the AMA just finally recognized racism as a social determinant of health. So yes, I think we're all moving in the right direction. So yes, there's always room to grow.
Another question that we have here is, how should health officials be communicating with hard-hit populations to ensure they trust the vaccine enough to take it?
I think, again, it gets back to working with trusted members within the community. For a lot of our hard-hit populations, social norms go a long way. And even I, as a provider, have had the experience where patients will listen to their mother-in-law or their cousin before they follow your recommendations. So to the extent that you can get that you can build relationships with key leaders within the community and have them be part of the dissemination plan for the information about the vaccine and encouraging people to get the vaccine, I think that will go a long way.
Dr. Pupes, anything else you would like to add to that question?
No, I agree with that, definitely. Yeah, I think just, you know, really thinking about who in every stage of healthcare we're involving in this process, and that's really important for trust building.
Thank you. We have here another question. and is Buffalo. I believe the person is in Buffalo. So Buffalo civic leaders have started a health equity task force, and many community leaders have talked for the first time during the last couple of years about meeting people of color where they live and really hearing them out. Can you give some examples about how similar efforts elsewhere that have borne fruit and impacted health outcomes?
Not my area. It sounds like it's asking about cities that have health equity groups. I don't know if our practitioner knows any or the reporter.
I need clarification on the question. So is it essentially asking about whether or not having healthcare workers residing within a community has led to improved population health outcomes or community health outcomes?
Yeah, I think so. I say because the person is giving an example of how in that community, leaders are talking for the first time, meeting people of color. So, and where they live. So I guess more in community-based meetings. So they wanted to know if any of you guys can give some examples in any other areas to see where they actually was effective to improve the health outcomes.
I can't name any specific examples, but theoretically, I believe that is an effective way to better understand a community which you're serving, which you're supposed to lead. I would like to think that would result in positive outcomes, depending on how it's been carried out.
Thank you. And here's another question. So can any of you guys identify sources of data or other information that journalists can use more effectively to report about connections between health disparities and infectious disease?
Yeah, I suggested APM Research Lab. They do some really good work on this. Stanford University has done good work on this, and most colleges of medicine, and I think the other two experts probably know this better than me, but I know at the University of Arizona College of Medicine, there's a whole team of people who specialize in health disparities and can help link reporters up to sources for that if you're looking for data. And I don't know if you have anything else you want to add to that.
Yeah, I think that's a good point. Institutions are a good source, and certainly at Hopkins we have a lot of health equity work and an institute around it. Many other places do, and I think that they're a really good source for data, both in-house data and pointing you to other resources.
All right, and another question that we have here is, what efforts works best after deep discussions in communities to improve health outcomes?
I think it's the actual action that happens after the discussion, right? Like we need to actually do things, whether that's implement policy changes or certain organizations taking the lead on different activities that are targeting a particular service or a particular health behavior. So yes, I think it's the action that happens behind those conversations. And of course, depending on what outcome you're trying to achieve and where you currently are, that often dictates what the next steps need to be.
Thank you. And trying to see the questions here, making sure that I did not miss any one or skip one so far. So another question that we have is, what stories would you like to see journalists write about? To Dr. Pampasolo to Alvarez.
Yeah, I think lots. I really liked what we heard about the personal stories about, the impact of these health disparities. I think that helps people connect to it. I mean, one thing that I run into both in my research and in talking to people about it is it can feel very abstract to them. So I think that real personal stories about it are valuable. I also, of course, am biased in thinking about the science of it. Like I said, I think that there are people that think that it's, certainly there are environmental impacts and cultural and behavioral and all of those things. There's lots of that. But I think that it is important to also recognize that some of it, has a real kind of scientific molecular basis we can point to. And those are things that we can then mitigate, as part of a multi-pronged approach to try to reduce health disparities or, totally get rid of these health disparities. So I would love to see, I think, more of that science being reported.
Okay, thank you. And one key element of social determinants of health is access to food. And now with the pandemic has increased the challenge of food insecurity. Are you seeing successful efforts to alleviate this problem that may be used in different communities? Dr. Alvarez, Dr. Pempas?
So I'm aware of some community organizations that are trying to supplement in a way what food pantries are providing. I know that some schools have opened for the purposes of being able to make sure that children are getting at least one hot meal a day. That's about all that I know of regarding efforts to alleviate food insecurity. But it seems that it's being done mostly at the community level.
Okay, thank you. Dr. Pampas, what else can we do, or what else needs to be done to break the barriers to have diversity in clinical trials, not only at the patient level, but like you mentioned, at the level where those people running those trials? So how can we break those barriers to be more inclusive and be diverse?
I think that's exactly it. So certainly we need the trust and we need to, improve in the patient population, but I think really diversification of the people involved. You mentioned the folks running the clinical trials, conducting trials at sites or, at HBCUs, for instance. We have great HBCU medical schools. Having those as sites, they have wonderful physicians and physicians in training as well as scientists in training, and across the whole, country and globally, at places where we have, people of underrepresented backgrounds that can run these trials. So I think that that's important, leadership of the trials at the physician level. But also I really like to think at that scientific level too, before we get to the trial, so that we know what to even look for, so that we understand how diverse the trial really, scientifically should be. That can help lead it. And, early on, we can start thinking about what are some of these differences we might see and, hopefully start to act on that earlier. So I think diversifying the scientific workforce, the medical workforce, diversifying who is included, who's given the chance to be a part of leading these trials and leading these scientific efforts is really critical.
Dr. Pepes, we had talked about trust in a different part of the session. Do you feel like it's maybe trust an issue too to get those patients to participate?
Certainly trust. And I think that if folks know, we heard about the trust with going to the doctor, not having doctors that look like you and understand your family. Same thing. There are a lot of the same barriers and, even increase because of much of the history as far as clinical trials and the way that we've treated people in those trials historically. So I think that, having physicians leading the clinical trial, having the community workers that are helping to do the recruitment, the nurses involved in a critical role. And like I said, if people know that there were, scientists that look like them, I'm hoping that builds trust too. So I think that it's something that we have to think about, just like we're recognizing it in general healthcare. I think we have to extend that to thinking about research and clinical research too, as far as that trust building.
Thank you, Dr. Pempas. Dr. Alvarez, you mentioned language barriers, and that's a big challenge how can we improve to serve better those hard-hit populations? Like you mentioned, in the Latino communities, it's not just Spanish. There's so many language, so many different language depending of the state, the country of origin or the indigenous background. So how can people break the barrier to be able to communicate with those populations in the native language?
I think something that we need to work on long term is increasing access to healthcare education for our increasingly diverse populations, right? So what can we do to recruit more people from diverse backgrounds to serve in our healthcare industry so that we do have a population of healthcare workers that reflects the diversity of our population at large.
And Dr. Underlies, you also mentioned that talking to the group in your trial and your group, many of them about the mental health disparities. How are you able to communicate with them? Because I know that in many Latino families, talking about mental health is a taboo. It's like no, we're not, we don't talking about that. We don't even want to go see a person. How are you able to convince them to be even part of and get help or even be part of the group?
Mm-hmm. Thank you. Yes. So we often talk a lot about mood and feelings. So not necessarily using specifically the words depression, anxiety, or even mental health. We focus on, we talk about having a project that is geared towards helping people improve their mood and better manage their stressors. So we start very generally, and yes, they've shared with us as well that, for those that are more recent immigrants, that they didn't hear about depression or anxiety until they came to the U.S. That those are just to your point, that this is a topic that is very taboo, that is not discussed in many of our communities within Mexico and Central America. So it's eye-opening for them. A lot of them do welcome learning that they are named for the symptoms that they're experiencing, and that alone can sometimes be very empowering and be encouraging for people to continue on their road to recovery and decreasing their symptoms.
Thank you. Do you think that eventually we're going to be able to break the stigma of mental health in communities of color and be a norm, to be able to go to the doctor, the same way we go to the doctor when we feel sick because we got a cut or something? Do you think that eventually will be okay to just go to a mental health professional to help us when we're feeling down?
I hope so. This is such a common issue that's affecting everybody, particularly now. And so I would like to hope that, yes, we come out on the other side being more forward thinking about mental health, that you do need to be mentally well to be physically well. The two work together. And yeah, as they would say in Spanish, quisiera que sí. Yeah.
And Stephanie, you mentioned in your presentation, you mentioned how you presented one of your stories to your editors to be able for them to say yes. I know that right now, especially in the journalism business and newsroom, it's about clicks. It's like you pitch a story, and if they don't feel that they're going to get the clicks for it, they say no. So what tips will you have to reporters who are trying to get those stories who may seem boring to you editor? Any other tips that you can rely, either from your experience?
Yeah, I mean, struggle with this every single day. You know, I wrote this story, 5 reasons why COVID might be surging in Arizona right now, and they just love that story because it's got, you know, so many clicks, but it doesn't really present anything new. It's just, you know, sort of a summary. They like these sort of 5 things, 5 reasons, and I think that, you know, we're doing our readers a disservice by not giving them deeper stories. And I think, you know, I don't think I have an answer to this because I go to bed and scream about this all the time because I think the key is really doing both. You have to sort of feed the beast, give them the clicks that they need, but then work on the side on these stories. Like when I first asked about, you know, I want to do something on health disparities and I want to look at zip codes and compare, you know, cases to income to ethnic breakdown, and my editor was just like, you know, I want another 5 reasons why I don't want that story. So rather than push the issue, I've been working on that story on the side, waiting till it's fleshed out when I can give them something better. And, you know, usually if you give them a solid story, you know, they're going to want to run it. I just think you really have to have your ideas fleshed out because I find if I do something like proposed health disparities, they'll say, well, can you give that to me by Sunday? And it's Thursday, you know, and you need a bit more time than that to work on the story. So honestly, sometimes it takes working on it on your own, and sometimes, unfortunately, on your own time to do it. I think if you have an understanding editor, you can have that conversation. But I do think, unfortunately, part of the business right now is clicks. I don't think it's very. I think it's a bit short-sighted. I think we need those clicks, but I think we owe our readers something more substantive. And you know, the argument, the other side of it that my editor is always saying to me is, Stephanie, if people don't click on your story, then they're not really wanting to read it or it's not resonating with them. So that's also your job to make it resonate with them. And I see that point too. You know, well, if I write a story that doesn't get a lot of clicks, I do usually go back and say why, how could I have made this more appealing to a broader audience? Because honestly, if people aren't reading it, then your point, your mission isn't really getting fulfilled, right? But I also don't think we should be writing solely for clicks. I think we should be writing, you know, to advance, you know, stories that are out there that exist and need to be told.
Thank you so much for those tips and advice to all the reporters out there that are struggling to get those stories written because sometimes they just say no to you. So we are kind of almost at the end of the time that we have here. So I would like to get the forum back to you guys to see if you guys have anything else to add for something that we need to know, something that you feel like, oh my God, I forgot to mention this during the presentation or during the questions that we have. So I just kind of wanted to give you back the microphone to see if you guys have anything else to add for people that are watching and listening to us. Dr. Bubba?
Oh, nothing extra to add. Just, I think, instead, let's think as much as we can get folks thinking about the science. I think that'll really go a long way with these health disparities we're talking about.
Dr. Alvarez?
Yeah, just to do the best that we can to take care of ourselves from this pandemic. Make sure that we are sharing accurate information, and every little action that we take can make a difference in terms of protecting our families and our communities at large.
Ms. Inez?
Yes, and I think listening to Dr. Alvarez and Bumpus really has been thought-provoking for me, especially about the vaccine and, you know, how that might affect different populations. And also, whether they're actually going to get the vaccine, and is there going to be enough outreach to them? And I really see that as a story moving forward for journalists, because that could really play out in another situation where underserved communities aren't getting the health care that they need. So I think for journalists, I'm just hoping that myself and others, that we can listen and tell the stories that need to be told to the communities out there. One thing I didn't mention was that I know USA Today did a little bit of this work where they looked at actual communities and how COVID had devastated sub-communities, small communities, often communities of color, and I think that's also a good way to tell this story.
Thank you so much. I just want to remind those who are listening to us right now that we are doing the breakout room following the conversation, so please hang around for that. And I just want to say thank you to all three of you guys. You guys were awesome. I appreciate you guys giving us the time to share your knowledge with all health reporters across the country. So thank you so much for attending, and that's the end of our presentation.
Thank you.
Maria.
Thanks, everyone.
Thank you.